And we move on then to the planning round for 2015-16. I will invite Simon to say some words by way of introduction and then Ian to present the paper.
So I'm essentially going to hand straight over to Ian, but just with this one sentence preface, which is there is clearly a balance to be struck for 15-16, which is that we want to continue to make progress on a number of the important goals that the NHS and our patients hold dear, including the mental health objectives we just talked about, various other things. Equally, we recognise that it is going to be very tight financially and the pressures are quite substantial. So there is a balance between aspiration and realism that will need to be struck. And in general, we want to minimise the background the changes that aren't essential to driving frontline improvement in care.
Thank you very much. Our aspiration for planning for 15-16 is a process which is simpler, that is more useful to NHS organisations and is more joined up between the different national parties. And I would particularly like to draw out three themes from the paper. So the first is our proposition that the main focus of the planning process should be a refresh of the second year of the operational plans that have already been developed by the NHS for 15-16, and that we really focus more clearly and effectively on the core aspects of planning activity levels and planning the financial arrangements so that we get an honest an effective reconciliation between those across commissioners and across providers in order to deliver financial balance and the NHS Constitution standards. And that will require, as Simon has outlined, a more close partnership arrangement between ourselves and Monitor and the Trust Development Authority. And the letter that Simon has already alluded to from David Bennett, David Flory and himself highlights that aspiration not only in relation to operational performance in 14-15 but also the construction of operational plans for 2015-16. We need also, as part of that, as Barbara has indicated, to make sure we achieve effective joining up between these plans and the plans that are already being constructed for the Better Care Fund. So that's my first point. Linked to that, as Simon has said, given the challenging context that the NHS is operating within, we are not proposing to introduce new requirements for 2015-16, other than, and I would particularly highlight the commitment to introduce new mental health access standards, as already mentioned in this meeting and at the annual general meeting yesterday evening. This picks up on a commitment in the current mandate that NHS England would be working on this. And the fact that we're only proposing to focus on this is in line with the proposals from the Department of Health not to introduce additional mandate requirements for NHS England. The second theme I wanted to highlight is the need for the NHS to continue the process of transforming care through the work that has already been done on the 5-year strategic plans. And we will be looking to encourage local systems to press on with those plans as they have been intending to do, but within the context of the 5-year forward view. Our initial thinking is not to require local organisations to write essays and fill in lots of templates in relation to that second element of transformation. The key thing is how do we make it easy for the NHS to focus on what they want to do by way of wider transformation. And the third theme I wanted to highlight are the changes, the evolution to the current commissioning system to help facilitate both better planning for 15-16 and indeed the delivery of the transformation of care in the longer term. And there were three elements of that I wanted to just highlight, one of which is the new integrated personalised commissioning programme, on which NHS England, with its partners, including notably the LGA and the voluntary sector, has set out a prospectus for local organisations to come forward with propositions around increasing personalisation by joining up at an individual level the budgets for health and social care. Secondly, we will be continuing to work, and our thinking is still at an early stage on this, around how best to empower CCGs to become more involved and engaged in the commissioning of specialised services. And thirdly, the next steps on the programme to enable co-commissioning of primary care with CCGs. On that last point, there is a joint group which has been established with NHS clinical commissioners and the Commissioning Assembly to work through how we best take this forward with CCG partners and indeed the area teams. And we are planning to set out the remaining policy design questions and choices for CCGs before inviting formal applications. And we're planning to issue that at the moment in November. And within that guidance, we will be particularly looking to ensure that there is a simpler set of processes, there is more information to CCGs about the choices that they have, and clear arrangements for dealing with potential conflicts of interest. So those, I think, are the three themes I wanted to highlight in the paper, and obviously very much welcome the reflections of the board on the proposed approach.
Ian, thank you very much. Let me invite the board to put questions or comments. I have Kieran.
That's great. How do we guard against optimism bias? Next year, life expectancy will be 3 months more than it is this year. We'll have a higher number of older people. Very tempting to try and balance the number, the activity that's put into the plan and the money, and make, how do we know that we're going to be realistic, that the plans are going to be realistic, and we're not going to wake up next year with a nice surprise that actually there are more people being treated and there are more people who are older, but actually, we're not quite where we thought we were.
Shall I maybe comment on that? Because clearly we'll put in the usual assurance processes. I think it largely stems from understanding the trends in this year, actually. There's a lead across from really understanding what's going on at the moment into the 15-16 plans. I was going to say a little bit more about that in a subsequent agenda item, so perhaps won't steal the thunder now. That, I think, will inform a better understanding of what the trends are. 15-16 is a critical year for that, of course, because we have the Better Care Fund, which will itself have impact on activities and growth and all that sort of stuff. So I think it is a very significant piece of assurance we'll have to do around that, and it does link to what Barbara was talking about earlier on the Better Care Fund and the assurance around the activity implications of that. Barbara, might you add to that?
Absolutely. This is a kind of complex and sophisticated piece of work, because whilst Paul is absolutely right that the trends for this year are key, what we do know is the trends vary in all the different parts of the country. So we are seeing different bits of the country with differential numbers of rises in referrals or increased numbers of emergency admissions. And of course, everywhere across the country, we've got health communities and social and local authorities coming together in the system resilience groups to try and work out what their plans are through the Better Care Fund. The Health and Wellbeing Boards and the Better Care Fund are an integral part to this, to put in place a range of interventions to try and keep people well and to try and keep them at home. And the degree of sophistication that our frontline staff need to support CCGs and their partners in the individual local health communities to understand the impact of all those interventions and the degree of confidence we have in those interventions in achieving the final numbers. Because sometimes the changes we see are about one health community being ahead of others, and therefore they've determined that a set of changes to the way that they deliver primary and community and social care services has a big impact on either referrals or, more likely, emergency admissions. So they will see a fall at a specific time, but then once they've had that impact, they won't see the continuing fall, whereas others who are further behind, who hopefully learn from that, will then move on. So a lot of work to be done, but absolutely we need to be sure that all parts of the service have got a plan which actually meets a reasonable ambition of what they want for their patients.
Moira.
Following up my earlier question, really, paragraph 22, the alignment of Commissioner plans with providers. Has that suddenly become a lot easier with this agreement with Monitor and TDA, or is it still a very difficult and demanding task?
I don't understand. It is absolutely easier, but in the final analysis, CCGs and NHS trusts, and particularly foundation trusts, are independent statutory bodies, and they have to assure their own boards and governing bodies that what they're assuming for their organisation is right for them. So the really critical job of facilitating and bringing people together so that those plans are aligned is key. We are seeing a big difference, particularly with the regional tripartite arrangements. I think the regional tripartite arrangements, so the working together of our people more locally, is probably at least as important, if not more important, than anything we're doing nationally.
When you use the word refresh in relation to those plans, I mean, it could cover a wide range from no change through to complete rewriting, much of which then is predicated upon the strength of the original plan. Our overall intention is that this is incremental change rather than fundamental change, but what assurance do you have about the amount of replanning that's going to be needed to be done across the whole CCG landscape?
That would be very much a function, as you say, of the quality of current plans. And Barbara, if I can pass to you, because your team has been involved in the assurance process.
I think CCGs as new organisations had a great deal of work to do last year to develop 1-year plans, 1 and 2 year operational plans, and their 5-year strategic plans. I think that the quality of the 2-year plans, the information in the 2-year plans, was not really robust enough as we move into next year. So I think the biggest single issue now is going back around the operational plans for the next financial year, because I think we've learnt a lot from this year. I think that we have a lot of analysis of information, of trends that we've seen this year, and I think we've got more experienced organisations and a much better tripartite infrastructure to support them, which means that we need to pay a lot of attention to the particularly the activity planning in order to deliver a range of things. And this is not just about the kind of constitution standards that we understand so well. It's not just about 18 weeks in A&E, but it's about really important things that we want to do, some things around learning disabilities, things around mental health, things around dementia. So across a range of things that CCGs and we in partnership as commissioners need to deliver across the board in partnership with providers.
Good, thank you. Right, well, Ian, thank you very much for the report, and Barbara and Paul for the supplementary observations. We know that this is work in progress, and we know that it's going to come back to us, but I think the board finds assurance as to the 3 items that you've mentioned, Ian, and we look further to forward developments.